Mouth care for residents in continuing care. Mouth care planning using the Ryan disablement process and mouth care decision trees. This presentation is for RNs and LPNs. During this presentation, we will review developing mouth care plans using the RY MDS and information gathered from the HCAs and family members. We will also review the decision trees that are used to guide the care provided to residents. Please refer to the handout entitled Mouth Care Planning Using the RY and Disablement Process and Mouth Care Decision Trees. Alberta Health Services has developed a mouth care training program to support healthcare providers in continuing care facilities address the daily oral healthcare needs of their residents. When information flows between the healthcare team members, the residents' changes in oral health needs can be addressed sooner. This results in better overall health and quality of life for your residents. The RY MDS assessment provides valuable information on the resident's level of independence that directly impacts the resident's ability to provide adequate, independent mouth care. Welcome to this session on mouth care planning using the RY and disablement process and mouth care decision trees. Mouth care is no longer considered a grooming activity like washing the face and combing hair. Mouth care is an important infection prevention procedure to remove bacteria from the mouth. Daily mouth care in the morning and evening helps prevent infections. A clean mouth can reduce the risk of tooth decay, gum disease, and lung infections or aspiration pneumonia. Goal number 1. Every resident has a mouth care plan to address their current level of independence and oral status needs. Following each RY assessment, use the data gathered to develop a custom mouth care plan. Communicate this plan to the caregiver performing the daily mouth care. First, gather information required for mouth care planning from the RY assessment. This includes ADL and CPS scores to determine the level of independence, oral concerns, and the level of consciousness. Ask family and staff about challenges to mouth care. Are there dental supplies available? Are there swallowing or choking concerns, or have they noticed food pocketing? How do they respond to oral care? Next, you will use the ADL and CPS scores to determine the level of support required. Decide how frequently the mouth needs to be rechecked for bleeding or debris. Select a mouth care protocol based on the choking risk. Consider resident safety when recommending products. And finally, determine what plan you will follow to deal with any identified oral health triggers, such as pain or swelling. Activities to daily living are a significant part of the RY. As ADL abilities decline, the resident needs more support from others to manage day-to-day tasks. Evidence points to 3 distinct stages of decline in the disablement process. Early loss. Performance of personal hygiene tasks starts to decline. Often this is a contributor to individuals entering the continuing care system. Middle loss is a time of change in locomotion. Someone previously getting around with a cane may now require a walker or wheelchair. In late loss, the path of decline continues and residents require more support with activities such as eating. Increased scores in cognitive performance, CPS, indicate greater cognitive impairment and have a parallel path with the decline of ADL scores. We can use the ADL and CPS outcome scales to assist us in mouth care planning. We will discuss this on the next slide. The mouth care planning with the RY tool is based on the disablement progression model. Most residents in long-term care are in various stages of physical loss, cognitive loss, or both. The RN or LPN uses the resident's ability to perform activities of daily living and their cognitive performance status to determine the type of oral health care support the resident needs. No loss indicates the resident can do activities of daily living and has no loss of cognitive skills. Residents in this category may only need assistance to get ready to brush their teeth or clean their denture. Early loss indicates residents in early stages of disablement who may struggle with personal hygiene tasks. These individuals will need caregivers to act as coaches to assist with getting organized and keeping on task. Middle loss are residents showing challenges with locomotion and toileting tasks. Assistance becomes more involved. As cognition declines, different strategies can be used to keep the resident involved in their personal care. These will be reviewed in the module on managing challenging behaviors. Late loss in the disablement model indicates residents are challenged with feeding themselves. These residents will require full support for their mouth care. Residents with high aggressive behavior scale scores may benefit from a two-person assist. There are a small number of residents who exhibit aggressive behavior or extreme responsive behavior. It may require two staff to provide support for their daily mouth care. Coordinate a two-person assist for these residents, rather than not performing mouth care. Goal number 2. Mouth care is performed 2 times per day. Oral care may be more often for residents with a dry mouth. Palliative mouth care needs to be performed more frequently. It is recommended to provide mouth care to moisten the mouth every 2 hours for patient comfort and to maintain health of oral tissues. This could be done when the residents are turned every 2 hours. What to record? Has the mouth care been performed or did the resident refuse? How and where will it be recorded? Each center may be different on their method of collecting this information. If a resident consistently refuses mouth care, who will address this health issue? The RN, the LPN, the nurse educator? Who needs a plan? Every resident needs to have an individual mouth care plan as a part of their overall care plan. This includes independent residents who perform their own mouth care or residents who need complete support for mouth care. What are the benefits of a plan? A plan provides you with information on how to support the resident with their mouth care. A plan helps you follow the best protocol for performing mouth care 2 times a day or 1 time per shift or more often if needed. There are 4 basic principles to the plan. Provide the appropriate level of care needed to support the resident. Ensure mouth care is done twice a day. Perform mouth care with a soft toothbrush that is the right size for the patient's mouth. Use fluoride toothpaste to protect the teeth and root surfaces from decay. Fluoride, calcium, and phosphate in toothpaste is left in the mouth after brushing and is particularly helpful to maintain a healthy mouth for the resident with less saliva or dry mouth.
Infection prevention and control best practice protocols for continuing care indicate the following practices that should be considered when performing mouth care procedures like brushing of natural teeth, care of gums and soft tissues, all denture care, and oral assessments. Assessing the task, the resident, and the environment. Routine practices are to be used with all residents for all care. Performing a risk assessment is the first step in routine practices. Before each resident care encounter, do a risk assessment of the task, the resident, and the environment. For mouth care, consider the notes box in the right-hand corner of the slide, blood and body fluids exposure. Mouth care includes brushing of natural teeth, care of gums and soft tissues, all denture care, and oral assessments. During mouth care, saliva will be encountered, blood may be encountered, and nasal secretions may be encountered. Consider, will my hands be exposed to blood or body fluids? Yes, your hands will be exposed to saliva and possibly blood during mouth care. The solution? Wear non-sterile gloves that fit your hands properly. Will my eyes or face be splashed or sprayed with blood or body fluids? Possibly, you may be exposed to droplets. The solution? Wear mask and eye protection.
No matter what level of support a resident may fall into, there are 2 protocols for mouth care: basic mouth care or modified mouth care. When selecting a protocol, consider the resident's ability to manage fluids without choking or coughing. Saliva, excess water, and the amount of toothpaste are the fluids to consider. The toothpaste display on the right shows visually how much toothpaste is needed to get the health benefits from toothpaste without increasing the choking risk. This slide pictures the areas that need to be brushed. Let's review the basic mouth care protocol. Before brushing, apply water-based moisturizer to the lips and use a grain of rice to a pea-sized amount of fluoridated toothpaste to protect the teeth from decay. Brush the teeth 2 times daily. Use a 45-degree angle and gently vibrate at the gum line to loosen the debris. Brush the outside, inside, and chewing surfaces of the teeth. As well, brush the soft tissues of the mouth, the tongue, cheeks, and the inside of the lips to remove bacteria and freshen breath. After, encourage the resident to spit out excess saliva, debris, and toothpaste. For maximum benefit, do not rinse the mouth immediately after brushing. Apply water-based moisturizer to the lips. And finally, rinse the toothbrush thoroughly and stand with the bristle end up in a cup to dry. The modified mouth care protocol focuses on managing saliva and debris in the mouth to reduce the risk of aspiration during oral care. There are 3 key differences between the modified mouth care protocol and the basic mouth care protocol. In the modified mouth care protocol, 1. Brushing is accomplished with a moist toothbrush and no toothpaste. 2. Saliva and debris is collected on a clean washcloth or paper towel throughout brushing. And number 3, fluoride toothpaste is applied to the teeth after brushing. This mop-as-you-go technique is used for individuals with identified swallowing problems or who are confined to bed. It is often helpful for residents who exhibit responsive behavior to toothpaste. Using a brush moistened with water may help reduce challenging behaviors. Other helpful tips on using the modified toothbrushing protocol are to position the resident as upright as possible. Ensure you rinse out the toothbrush frequently during the brushing to remove the stale tasting plaque and debris. This slide demonstrates how to apply fluoride toothpaste after brushing when using the modified mouth care protocol to avoid choking. The slide on the left is showing the clear muco-lubricant and the blue toothpaste on the caregiver's gloves. For easy access to these products, apply them to your glove prior to mouth care. After cleaning the teeth, apply a rice-sized amount of non-foaming fluoride toothpaste to all the natural teeth for protection from decay. Use mop-as-you-go technique to remove saliva and excess toothpaste. And for maximum benefit, do not rinse the mouth or drink immediately after. Does this technique really work? Let me tell you Leon's story. Leon is a middle-aged man with end-stage multiple sclerosis. He consumes only pudding and thickened fluids, and he experiences choking episodes with every meal. Staff are uncomfortable providing mouth care for Leon as it always leads to coughing or choking episodes. Leon's teeth are covered with heavy debris and plaque, and he has very bad breath. After taking the mouth care training, the staff utilized the mop-as-you-go method with a moist toothbrush, a terry towel washcloth, and a cup of warm tap water. The first brushing took about 10 minutes to remove the heavy debris. This time included breaks for Leon to relax and swallow that subsequently reduced his choking and coughing. Staff noticed immediately how clean his teeth looked. Soon, time for future brushings was down to half, and anxiety around mouth care was significantly reduced for both Leon and the care staff. Dentures should be removed from the resident's mouth every night to let the tissue under the denture rest. The denture should be cleaned in the evening and soaked in water or a denture solution overnight. Always wear gloves for denture care, whether removing a denture from a resident's mouth, cleaning it, or placing it back in their mouth. Some residents have worn their dentures at night for years. In this case, encourage the residents to leave their dentures out overnight. If they insist on wearing them through the night, then encourage them to remove them sometimes during the day, during a nap time, or at some point in the day when not visiting with family. 4 to 6 hours with the dentures out will allow the gums to breathe. In the morning, rinse and brush the dentures thoroughly to remove solution and any remaining debris. If the chemical solution remains on the denture, then the resident could develop mouth sores. Ideally, dentures should also be rinsed after every meal to remove food debris from and under the dentures. Clinical nurse educator Kathleen will be joining us to assist on some of the following slides. The mouth care decision trees are designed to assist in the identification of potential oral health triggers by all long-term care staff. Once an oral health trigger is identified, it is reported to the RN or LPN responsible for that resident. The RN or LPN uses the decision points to determine if there is a need for further assessment and intervention, for referral to the appropriate dental or medical professional, or an action to manage the oral health issue. Identifying problems early results in less pain and discomfort for the resident, less costly treatment, less inflammation, and fewer infections. It also results in improved overall health and well-being and improved social interaction. Some diagrams include notes for conversations with family. They are found in the green boxes. This slide is showing one example. When discussing the need for dental treatment with the family, choose the specific item that is relevant to the resident. Weight loss, loose teeth that can be aspirated, increased risk of pneumonia. Each box has information relevant for the oral health condition that the resident is experiencing. At the bottom of this box is funding information on Alberta Dental and Optical Assistance for Seniors program for low-income seniors. This provides up to $5,000 every 5 years to seniors on a sliding scale based on the level of income. This diagram is on page 10 of your handout. It focuses on chewing problems and mouth pain. Triggers are on the left side, decision points in the center, action items with a no response to the right, and there's a referral box also in the center with yes responses from the decision points. Observable triggers may impact the resident's ability to chew or may cause mouth pain or a systemic infection. Regular observation increases confidence in understanding and reporting triggers to the RN or members of your team. Mouth pain triggers should be considered recent changes from previous observations. Here's our first example, Kathleen. The family reports that the resident has had a habit of grinding his teeth for years. Is this an observable trigger?
No, it's not an observable trigger as it is not a new habit.
Right. You want your team to report any recent changes. If the resident has recently started grinding his teeth just in the last few days or weeks, this may be an indication of changes in the mouth or cognition and should be checked out. Here's another example. The resident has recently stopped eating and refuses food. The resident could be experiencing pain from any number of problems, so we see it as recent. What might be causing the refusal of food?
Possibly a cavity or a broken tooth, but it could be a sore throat or a sign of depression.
Yes, those are all possible answers. There are 2 dental diseases, tooth decay and gum disease. Both of these can lead to dental abscesses. Also look for chewing problems related to missing teeth, broken teeth, poor fitting dentures, dry mouth, or dental pain. Watch for signs of oral cancer on the tongue, lip, or cheek. Go to page 11, diagram A of your handout to see the entire decision tree protocol on the issue related to natural teeth. What do you see in these pictures, Kathleen?
These slides show teeth that have cavities. The top left photo shows teeth with very large cavities, and the top right photo shows teeth that have decayed right to the gum line.
Yes, there are roots still remaining in the gum and bone, and they're at risk of infection. Both of these residents are most likely in pain or discomfort with cold and or hot foods or when chewing food or laying down. Be specific when you ask the resident questions. If you're not able to ask, observe the resident while eating to determine when the pain occurs. Either way, these teeth have a high risk of infection and need to be referred to the dentist for assessment and treatment. The lower photos show tooth decay along the gum line. This could be caused from poor brushing along the gum line or perhaps dry mouth. The medical doctor may need to prescribe an antibiotic or pain relief medication prior to a dental appointment and needs to assess the resident's health to determine if they can attend a dental appointment. Many of the teeth in these photos may need to be extracted as they are no longer restorable or able to be filled. On pages 12 to 14 of your handout, you will find diagrams B1, B2, and B3. The next slides help you identify triggers related to soft tissues. Consider the tissue of your mouth about the size of the peel of a mandarin orange. If you peel the skin of a mandarin orange in one piece and place it on your forearm or upper thigh, it covers a significant portion of skin. This is about the same amount of tissue surface that is found in a typical mouth. If this amount of skin was inflamed and bleeding anywhere else on the body, there would be a wound care protocol in place for this resident. When the gums are red, swollen, and inflamed, this is called gingivitis. Do you know the main sign of gingivitis?
Bleeding gums.
Right. How would you treat that, or what action would you suggest?
I would recommend careful daily brushing to see if the bleeding and inflammation subsides.
Correct. If daily brushing is thorough and consistent, bleeding will lessen each day and gum health will improve within 1 to 2 weeks. If bleeding does not stop, then refer the resident for a professional cleaning by a registered dental hygienist. As an RN, is there anything else you need to consider when you encounter bleeding?
I would also consider reviewing the medical history for any other sources of bleeding gums, for example, blood thinners or low platelet counts. I would consult with the medical doctor on mouth care protocols for these specific residents.
What do you see in this slide?
The top slide is showing a yellow hard deposit on the lower front teeth and some brown coloring along the gum line of the upper teeth.
This is the deposit of calculus or tartar and cannot be removed with just brushing. Only a professional cleaning by a dental hygienist can remove these deposits above and below the gum line. After the cleaning or scaling appointment, then the gums may take 3 to 7 days to stop bleeding. The bottom slide is showing the same teeth after the cleaning and removal of the hard deposit. The upper left photo shows facial swelling. This may be observed at any time, not just at mouth care time. This situation is very serious due to the presence of facial swelling and the risk of septicemia and brain abscess. This needs immediate medical and dental attention. The resident may or may not express pain if an abscess is present. The other 3 slides could be observed during mouth care or during an oral assessment. Any lumps, bumps, sores, or pus coming from the gums is a sign of infection, and the resident needs a dental appointment as oral infections do not resolve with antibiotics alone. Dental treatment is required. While antibiotics will reduce the infection for the short term, they will not fix the problem. The infection will return unless the source of the infection is treated. If bad breath is noticed during mealtime or administering meds, then the mouth should be checked for an infection. We recommend that all staff look for changes in the color, texture, or shape of the tissues in and around the mouth, under dentures, and on the tongue. What would you like staff to report to you as the RN?
I think that some things that should be reported and recorded would be color changes in the mouth. White, red, yellow, anything not normal skin color. Also, what concern is the staff member noticing? Open sores, ulcers, rash or coating in the mouth, oozing substances, or any lumps and bumps.
Most mouth sores may resolve in 1 to 2 weeks. This may take a little longer in residents with diabetes. Sores that persist and are not resolving should be invested further by medical consultation. Then follow the decision tree for management. Next, we will look at issues related to dentures, fit, and function. Please refer to page 15, diagram C of your handout. Let us briefly review the types of dentures and their function. In this slide, we see complete dentures. They are used when all the teeth have been extracted in the upper or lower arch. Complete upper dentures are kept in place or retained by suction between the denture and the roof of the mouth. As a resident loses weight, the denture fit will change. The denture may need to be relined to adjust the fit and ensure it is properly retained to allow the resident to chew and speak. Complete lower dentures are retained by sitting on the bony ridge of the lower jaw. This ridge often shrinks or disappears with age, leaving little for the denture to sit on and creating problems with retention. Dentures can float around in the mouth and become a potential choking risk for residents. In this slide, we see partial dentures. They are used when only some of the teeth are missing. Partial dentures are held in place with metal clasps, as shown here. They can be made of full acrylic or can be a combination of acrylic and metal. Here we see a complete lower denture supported by implants. Implants are becoming a more common treatment option for individuals wearing complete upper dentures or complete lower dentures. Implants are more commonly found in the lower arch when the lower arch has shrunk away and can no longer hold the denture in place. The picture on the left shows titanium posts surgically placed into the bone that extend through the gum. There are 4 individual posts. The picture to the right is of the attachment system inside the complete lower denture. It clicks into place and snaps out when removing. This keeps the complete lower denture tightly in place and allows the wearer to have confidence in chewing and talking. Implants are like teeth. The gum around them can experience redness, swelling, bleeding, and infections that can spread to the bone. The gum and implant posts require regular, twice-a-day brushing with a soft or ultra-soft bristled toothbrush. Where possible, ask the resident to remove their own dentures. If they are not able to do this on their own, the best sequence for removing the denture is to first remove the lower denture and then the upper denture. When reinserting, first insert the upper denture and then the lower. To remove partial dentures, use fingernails to get under the clasp and firmly pull down or up for lowers over the cusp of the tooth. Refer to page 16, diagram D of your handout. If the resident is missing teeth and has no dentures, assess the resident's desire for dentures. These slides are showing mouths of residents who may need complete or partial dentures. There are important questions to ask when considering dentures. Can the resident tolerate the denture and the procedure to make the dentures? Will the resident be able to adapt to wearing the denture after it is made? Let's look at some possible scenarios with these residents in these photos. What do you see on the upper left slide, Kathleen?
This resident has no upper front teeth. The resident or the family members may want to replace the teeth, especially for appearance.
Yes, that is often the case. On the upper right, the resident has no upper teeth. The folds in the tissue along the arch indicate that this resident has recently had their teeth extracted. There is a gum sore in the middle of the arch that may be as a result of a denture that is too tight or too loose. The resident is not wearing their denture due to discomfort. This sore and the resident not wearing the denture indicates it needs an adjustment. On the lower left picture, the resident appears to have no upper teeth. He has a partial upper denture that no longer fits. The upper arch has had most of the teeth removed a while ago. Is there something else you can see in the photo?
I'm also noticing swelling where that corner tooth has broken off, leaving the root remaining in the bone and possibly infected. This will need an appointment with the dentist to treat the infection.
Yes, and after that, the family could see if they were interested in a new denture. On the lower right picture, the person has some natural teeth missing and some natural teeth present. It appears that she does not wear partial dentures. The chewing ability of her current dentition is not great, and a modified diet may need to be provided. She would benefit from a dental appointment to fix broken teeth on the upper, clean the debris and hard deposit on the teeth. Depending on this resident's cognitive status and her desire to replace her missing teeth, she may or may not be able to adapt to new dentures.